Assalamu alaikum. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Rabbi zidni ilma, Rabbi zidni ilma, Rabbi zidni ilma. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Okay, today I would like to discuss about the rheumatology. It will be again the same strategy, like 10 to 15 page at a row, trying to discuss these things and try to clear the concept. Okay, moving on. What are the differential diagnoses of non-traumatic joint swelling? There is no trauma, but there is joint swelling. It may be infectious, it may be inflammatory or rheumatological, or it may be neoplastic. So infectious is always acute. We know that infectious is usually acute, and inflammatory or rheumatologic is subacute or chronic, and the neoplastic is subacute or chronic. Infectious, timing of the pain is constant, and rheumatologic or inflammatory is worse in the morning, and neoplastic is worse in the evening or night. In infectious, able to bear weight? No. In inflammatory, they can able to bear weight, and neoplastic is variable actually. Multiple joint in infectious, there is multiple joint is uncommon, but in rheumatologic there is involvement of multiple joint, and neoplastic is always variable. And the labs, WBC count, platelet is always high, and inflammatory marker is high in infectious. In inflammatory, WBC, platelets, inflammatory marker is high, but RBC is low. This is another differentiating point regarding labs. And in neoplastic, there may be low WBC and low platelet. So in neoplastic, it is low WBC and low platelet count. So if I am going to talk about joint swelling, non-traumatic, you have to divide in three parts: infectious, inflammatory or rheumatological, and neoplastic. And the lab investigation, if I'm looking for lab investigation, in infectious and inflammatory, there is increased WBC, increased platelet count, increased inflammatory marker ES or CRP. But in rheumatologic, there is decreased RBCs too. And in neoplastic, there is decreased WBC and platelet. If I am talking about the JIAs, I have to divide it into mainly three parts: systemic GIA, polyarticular GIA, oligoarticular GIA. I have seen multiple patients regarding GIA and treated in pediatric rheumatology department. In systemic GIA, frequency is 10% and age is less than 18. Age of onset is less than 18. The main things in JIA, you have to remember the clinical feature: arthritis more than one joint for more than 6 weeks. Arthritis more than one joint for more than 6 weeks with quotidian fever for more than 2 weeks, events and rash, quotidian fever, events and rash, hepatosplenomegaly, and lymphadenopathy. Arthritis more than one joint arthritis, more than one joint for more than 6 weeks. There is quotidian fever for more than 2 weeks, events and rash, quotidian fever, events and rash, hepatosplenomegaly, and lymphadenopathy. Polyarticular is 40%, age 2 to 5 or 10 to 14. There is arthritis, polyarticular arthritis more than 5 joints, 5 or more than 5 joints may be complicated with uveitis. Even in oligoarticular, which is neighborhood frequency is 50%, in here arthritis less than 5 joints and may be complicated with uveitis. In both cases, polyarticular, oligoarticular, female predominance is more. Age is usually smaller, age is 2 to 4, and associated with uveitis. Systemic GI is a very high yield topic, as it is, though it is the least common subtype, but it is more important. Arthritis more than one joint for more than 6 weeks commonly involve hips and knees and hands. Hips and knees and hand may have arthalgia, as in these may have arthalgia prior to the onset of the arthritis. So patient may have arthalgia prior to the onset of the arthritis, fever for 2 weeks, and fever for 2 weeks, and it is quotidian in temperature. It is quotidian in nature, in which high temperature spike once daily. High temperature in the evening. High temperature once daily in the evening, followed by spontaneous return to normothermia. Quotidian pattern means high temperature like 104 at the evening, then at night it becomes normal. An evanescent pink rash accompanies the fever, as seen in this type of patient. There may be hepatosplenomegaly and lymphadenopathy. Hepatosplenomegaly and lymphadenopathy are also common. Supportive labs reflect inflammation including leukocytosis, elevated ESR, CRP. There may be thrombocytosis, leukocytosis, thrombocytosis, hyperferritinemia. This is very high yield. Leukocyte count high, increased thrombocytes, increased ferritin, increased leukocytes, increased thrombocytes, increased ferritin, and anemia due to chronic inflammation. And iron deficiency anemia is also seen. Rheumatoid factor and anti-nuclear antibody is typically negative. Rheumatoid factor and anti-nuclear antibody is typically negative in systemic GI. In the setting of classic symptom, quotidian fever, events and rash and arthritis less than uh, more than 6 weeks of duration, a tentative diagnosis, more than 6 weeks of duration, a tentative diagnosis of probable systemic GI may be made. Then oligoarticular GI. Oligoarticular GIA is the most common, and involvement less than 4 joints, involvement less than 4 or less than 5 joints within the first 6 months of the disease onset. A limp is worse in the morning in a toddler girl. A limp is worse in the morning in the toddler girl is a typical presentation of oligoarticular GI. Joint swelling is present, but pain may be minimal. The large joint knees and ankles are most commonly affected. However, hip involvement are rare. Systemic symptoms, fever, rash do not occur. Uveitis, intraocular inflammation is a serious complication. Intraocular inflammation is a serious complication. So ophthalmologic screening may be performed because untreated uveitis may lead to vision loss. Untreated uveitis additional is leukocyte count, hemoglobin, ESR, and typically normal. Diagnosis is clinical. First line treatment is NSAIDs. First line treatment is NSAID, including then how different transient synovitis versus septic arthritis. Very high yield happens in children. Transient synovitis is a well appearing afebrile, low-grade fever child able to bear weight, and septic arthritis is ill-appearing febrile child non-weight bearing. Ill-appearing febrile child non-weight bearing. Diagnosis: normal or mildly elevated WBC, ESR, CRP. Normal or mildly elevated WBC, ESR, and CRP. And in septic arthritis, moderately elevated WBC, ESR, and CRP. Unilateral or bilateral joint diffusion or ultrasound. In septic arthritis, there may be a positive blood culture untreated. Unilateral joint diffusion on ultrasound. Synovial fluid WBC. In septic arthritis, synovial fluid WBC count is more than 50,000. Transient synovitis is a conservative treatment, 3 to 8 years old baby who came with the complaint of the limb. uh, there may be normal ESR, mildly elevated, normal or mildly elevated ESR, CRP, or WBC. It is a diagnosis of the exclusion, but septic arthritis is a medical emergency, and in here you should do joint drainage and antibiotic. When the diagnosis is unclear, bilateral ultrasound is performed. Joint effusion. Septic arthritis is unilateral, whereas 25% patient with transient synovitis has bilateral hip effusion. If hip ultrasound show unilateral effusion, arthrocentesis is required to evaluate the septic arthritis. Very high yield. If there is joint effusion, if it is unilateral, then you should look for arthrocentesis. If it is bilateral joint effusion, think about transient synovitis. So think about transient synovitis. So transient synovitis. Transient synovitis preceding viral infection. So transient synovitis age 3 to 8 preceding viral infection. Age 3 to 8 preceding viral infection. They are usually afebrile. There is limping pain hip pain. There is limp and able to bear weight normal or mildly elevated ESR, CRP, WBC count, and small effusion on ultrasound. It is conservative and NSAID is given. Full recovery within 1 to 4 weeks. Recurrence uncommon less than 15%. This is all about transient synovitis. It's a benign condition. Inflammation of the tissue surrounding the hip joint. Typical presentation: or thigh pain acute hip or thigh pain, limping, and decreased range of motion of the hip joint. Patients tends to hold of the affected hip in the flexion and external rotation. Patient tend to hold the hip in flexion and external rotation, and resist extension and internal rotation. They actually resist extension and internal rotation. Septic arthritis, Staph aureus, group B streptococcus, and gram-negative bacillus. Staph aureus, group B streptococci, and gram-negative bacillus. Generally, fever, fuzziness, and poor fitting. Joint is lack of movement, irritability with repositioning like diaper changes, irritability with diaper changes or repositioning, and asymmetric swelling. There is in septic arthritis, it is unilateral asymmetric. Septic arthritis in infant caused by Staph aureus, group B streptococcus, and gram-negative bacilli. Staph aureus, group B streptococcus, and gram-negative bacilli. There may be fever, fuzziness, lack of movement. In joint, there is lack of movement, irritability with repositioning, and asymmetric swelling. There is elevated ESR, CRP. There is elevated ESR, ESR, CRP. There is joint aspiration and antibiotic. Infants often lie with the hip flexed, abducted, and externally rotated. Abducted and externally rotated to maximize the joint space. Physical examination: hip flexed, abducted, and external rotated to maximize the joint space. Physical examination may reveal pain, active and passive range of motion, as well as asymmetric swelling. Flexed, abducted, and external rotated. Pediatric septic arthritis, age less than 3, more than 3, age less than 3 months. Staph aureus, group B streptococcus, gram-negative bacilli. Age more than 3 months. Staph aureus and group A streptococcus. Acute onset joint pain, swelling, refusal to bear weight, but in transient synovitis they can able to bear weight. Pediatric septic arthritis less than 3 months and more than 3 months, but transient synovitis in 3 to 8 years. Clinical feature is acute joint pain, swelling, limited motion, refusal to bear weight, fever more than 101 Fahrenheit. There may be increased WBCSR and CRP. There is blood culture, joint aspiration, effusion on ultrasound or MRI, joint drainage or debridement, IV antibiotic, joint drainage and debridement, and antibiotic. Septic arthritis should be suspected in children with acute onset fever and joint pain and swelling. Management includes empiric parenteral antibiotic, prompt surgical drainage due to risk of permanent joint destruction. Prompt surgical drainage will likely to be required to decompress the joint space and remove the infectious debris. If patient remains febrile, fails to improve after arthrocentesis, 48 hours of the antibiotic therapy, MRI should be formed to evaluate for concomitant osteomyelitis. This is very high yield. Arthrocentesis done. Still patient remains febrile. Even if you are giving the antibiotic, 48 hours it's gone. So then you should do MRI to look for concomitant osteomyelitis present or not. This is RA. This is joint fluid characteristics. This is joint fluid characteristics. Normal joint fluid characteristics is appearance clear, WBC less than 200, and polymorphonuclear neutrophil is less than 25%. Non-inflammatory, inflammatory, and septic joint. Non-inflammatory is osteoarthritis, inflammatory is crystal and RA, and there is septic joint. There is septic joint. Non-inflammatory is clear. Non-inflammatory osteoarthritis clear 200 to 2000, 200 to 2000, 200 to 2000, and PMN is 25%. PMN is 25. Inflammatory translucent or opaque 2000 to 1 lakh, and PMN polymorpho leukocyte is more than 50%. Septic joint opaque 50,000 to 1 lakh 50,000. Septic joint opaque 50,000 to 1 lakh 50,000, and there may be 80 to 90% of PMN. So non-inflammatory osteoarthritis, inflammatory is crystals like gout, pseudogout, and rheumatoid arthritis, and septic arthritis. Osteoarthritis usually more than 40, usually more than 40. Prevalence increasing with age. There may be knee, hip, DIPs, and fast carpo-metacarpal joint. And there may be fast carpo-metacarpal joint. Hip, knee, hip, DIP, and fast carpo-metacarpal joint. Morning stiffness, systemic symptom absent. Examination finding: hard, bony enlargement of the joint, hard, bony enlargement of the joint, reduced range of motion with crepitus. Hard, bony enlargement of the joint, reduced range of motion with crepitus. Osteoarthritis is due to degeneration of the articular cartilage, is usually an idiopathic phenomenon of aging, although it can also occur due to acute or chronic joint injury. Examination is periarticular bone hypertrophy, tenderness, limited range of motion with crepitus and pain, small joint effusion without erythema and warmth, varus or valgus angulation, popliteal or Baker cyst behind the joint, periarticular bony hypertrophy and tenderness, limited joint of motion, limited range of motion with crepitus, periarticular bone hypertrophy and tenderness, limited range of motion with crepitus, small joint effusion without erythema, varus or valgus angulation, popliteal cyst behind the joint. Osteoarthritis of the hand, primarily clinical diagnosis. Imaging is less sensitive. X-ray to confirm the diagnosis. Arthrosynthesis show clear fluid at the few inflammatory cell and can be helpful. Lab testing: inflammatory ESR CRP will be high, and in serologic markers are normal. Rheumatoid factors is normal. This is the osteoarthritis of the hip joint. There is loss of joint space. Osteophyte is shown. This is osteophyte. Subarticular sclerosis. Subchondral sclerosis. This is subarticular sclerosis. Osteoarthritis of the hip is characterized by chronic hip in the groin, buttock, buttock. In the lateral hip, there is it can radiate to the lower thigh or knee. It is worse with activity. And weight bearing. Examination often shows decreased rotational range of motion. X-ray reveals loss of normal joint space, periarticular osteophyte, sclerosis. This is hand osteoarthritis. This is osteophyte This is osteophyte. This is subchondral sclerosis. This is narrowed joint space. This is osteophyte, subchondral sclerosis, and narrowed joint space. Okay, look, this is osteophyte. This is subchondral sclerosis. This white portion, and in here there is narrowed joint space. Okay, and osteoarthritis usually more than 40, age more than 40. Osteoarthritis is a disease of the, usually disease of the older, age more than 40, chronic progressive hand pain or stiffness. There is DIP and PIP joint and fast CMC joint involvement. Examination: bony enlargement, Hayward node, Boscher's node, crepitus with X-ray joint space narrowing, subchondral sclerosis, periarticular osteophyte. Initial management is stretching and strengthening exercise and topical or oral NSAIDs. This is Washer's node in the PIP. This is Hayward node in the DIP. Risk factor for osteoarthritis: modifiable, non-modifiable, secondary, a sedentary lifestyle, obesity, occupational joint loading, diabetes, sedentary lifestyle, obesity, occupational joint loading, and diabetes. And non-modifiable, advanced age, female sex, family history, abnormal joint alignment, and prior trauma to the surgery. This is high yield. If there is anterior cruciate ligament injury, most patients with anterior cruciate ligament injury, they have the propensity of developing osteoarthritis within 10 years. So it is non-modifiable. Prior joint trauma or surgery is a very high yield risk factor of having osteoarthritis. Osteoarthritis management: non-pharmacological, exercise weight loss. Symptom persist, topical or oral NSAID, consider duloxetine, tramadol, and topical capsaicin, and topical capsaicin. Symptoms persist. Surgery if possible, and chronic pain management. Surgery is possible in chronic pain management. Initial management of osteoarthritis of the knee include weight loss, regular moderate activity of activity walking, exercise to strengthen the quadriceps muscle. Simple NSAID may be helpful, should be given a patient with peptic ulcer, coronary artery disease, and CKD. Dedicated exercise for strengthening the quadriceps can improve the function and protect the articular cartilage. If conservative management is inadequate, injectable glucocorticoid, possibly hyaluronic acid, may relieve the symptoms. Appropriate measures fail, then total knee arthroplasty, an elective surgery consisting of replacement of articular cartilage of the knee with prosthetic components. Total knee arthroplasty have been associated with improvement in pain level, function, and quality of life. Hinge unloader, hinge unloader, valgus, knee braces, transverse hinge unloader, valgus knee braces, transfer load from medial to lateral joint compartment are usually useful for patients with medial unicompartmental osteoarthritis associated with varus deformity. So osteoarthritis, rheumatoid osteoarthritis age more than 40 increases with age. Rheumatoid arthritis 40 to 60, often with younger. Osteoarthritis, knee, hip, DIP joint, fast CMC joint, knee, hip, DIP joint, fast CMC joint. But in rheumatoid arthritis is metacarpal PIP, not DIP risk. MCP PIP risks. Morning stiffness seen in rheumatoid, systemic symptoms seen in rheumatoid. Examination, there is soft, spongy, warm joint in rheumatoid, but hard, bony enlargement of the hard, bony enlargement of the joint in osteoarthritis. In next, there is narrow joint space and osteophyte, and periarticular erosion is seen in rheumatoid arthritis. So that's all. 8 page, first 8 page of rheumatology. Hope you enjoyed.